All right. Speaking of arm wrestling matches, we have the Uveitis panel. Nothing better than seeing Steve Ye and Tom Albini arm wrestle. I've witnessed it myself. It is worth watching. Thank you for joining us. We're going to take you into lunch here. It's my pleasure to talk to you about and present our panel. Nothing better right after a GA talk to have uveitis. Everything causes inflammation, as we know. Here are my disclosures, and as we're getting settled, this is my esteemed panel. Thank you, Tom, Vishali, Lucia, Jen, and Steve for joining us. Should be a lot of fun. I'm going to walk you through. So here's your preview slide. Let's talk about a few things. We're going to talk about CME treatment choices. We'll do a couple cases, meaning medication-induced retinitis, POHS with choroidal neovascular membrane. Can I stop the insanity? Follow-up is just a recommendation, and I am better because of Dan Martin. Let's go through it and talk first. CME data from a few years ago. We had the POINT trial. We had Peachtree. Both of these really kind of impacted, I think, how we think of cystoid macular edema in with uveitis. I'm curious, if I was your patient, think of a youngish 51-year-old Indian male without syphilis or TB, Tom, and I'm phakic, I have no nuclear sclerosis, 450 microns of OCT thickness. How do you treat me? Tom, what would you do?
Well, I mean, to be maybe somewhat controversial, I think, if it's a minimal CME, this is, 450, so this wouldn't be that case.
I'm 2050. I'm 450. Help me.
I think topical, sometimes does have effect. But my favorite go-to, I think, for kind of milder inflammation is a subtenon's Kenalog injection. Now, in this hypothetical with you as my patient, I'm sure that you're going to bring up the POINT data and have a vigorous argument with me.
Yes, of course I would.
And I would grab for the largest needle I could find.
Thank you.
That would be Ozurdex. And I think you could make a strong case for Ozurdex. I personally think that...
I've just asked you to pick one, honestly. I mean, that's what we're looking for.
I don't want to eat up too much more time, but the POINT trial showed that SDK was inferior, subtenon's Kenalog was inferior to the intravitreal modalities, and that's definitely true. I still think there's a place for it, though, with milder inflammation. I still use a lot of subtenons. That would be my choice for you.
Jen, what would you do? I had to cut him off there. He's taking too long.
Yeah. Well, I'm surprised he didn't retest you for syphilis.
I know. That's the kind of guy he would be. Jeez, wow. Tough crowd.
Second of all, I would probably go with intravitreal dexamethasone. Your vision's down.
Yeah.
The POINT slide that you showed, the data show or suggest that periocular group might catch up. But the reality is you were allowed to pick whatever treatment you wanted after 8 weeks, and a lot of those periocular people ended up getting Ozurdex during that 8 to 24 weeks.
Gotcha. Yeah. Steve, how about, are you going to give me a suprachoroidal steroid injection and make me hold my eye for a couple of hours afterwards? What are you doing?
Yeah, so I'll get to that. But first, I think it's just thinking about the patient in terms of there's some patients that are totally fine with local corticosteroid injections and others that lean systemic. You strike me as somebody that would be just fine with a local steroid injection. And so I think that because of this data, I mean, the one thing that you did not show is the Magnolia data that showed us the durability signal with suprachoroidal steroid. I think both intravitreal dexamethasone and suprachoroidal corticosteroid are great choices, but I would lean suprachoroidal.
All right, Lucia, what about you? I'm going to give you a word here. Going to give me difluprednate, please. Let me use something topically.
I'm giving you difluprednate. I like to start slow. I'm a conservative person. See if you have a huge steroid response or not before I go on to the others and take it slow.
Seems to make sense. Vishali, I'm coming to visit my cousins in India to get treated, and healthcare is cheaper and better. So what am I doing in India?
I would give you intravitreal dex implant.
All right, that's what I needed to hear. All right, so let's go ahead and talk about also being careful with local steroids. Don't unmask an infection like this patient who had syphilis who got a periocular steroid injection. So sometimes it's the medications. I have a 72-year-old male with decreased vision in both eyes, slowly worsening, has a history of hepatocellular carcinoma. He's on a tyrosine kinase inhibitor, and he's 2200 in one eye, 2100 in the other eye, 1+ AC cell and vitreous cell. Here's his photos. There's his view in the right eye. You can see the bunch of vitritis. In his left eye, also vitritis. And it looks like just this stuff in the outer retinal in both eyes. Just a little bit of whitening that I can see. The fundus autofluorescence showing us some hyperautofluorescence that's really profound and enlarged. There's the OCTs with the fluorescein also showing me profound amounts of the retina that's involved. So panelists, let me ask you a thought. 70-ish-year-old male who has carcinoma on a TKI inhibitor with bilateral pan-uveitis and CME. As you're thinking about it, Vishali, I'm going to show you a couple of other things. What do you think here in this patient? There has been some association with systemic inflammatory disease with TKIs, and we published a series of a patient who had metastasis with the same medication. What are you thinking when you look at a patient like this? What are your thoughts?
Sunil, there would be three possibilities. One is it could simply be a masquerade due to the existing disease. Second is the patient is immunosuppressed, so there could be secondary infections in the eye, which could be viral, which could be syphilis, which could be anything. And the third would be drug toxicity. I would look at the phenotype. If the phenotype is suggestive of some infection, I would first rule out that rather than putting the blame on the drug.
Okay, not blaming the drug, always a good
No.
thing at Subspecialty Day. Lucia, tell me, in your opinion, do you see anything here that is important to you? Are you thinking that this is more drug-related? Is there something else? How do you go about with these patients? Or there's a clue for you on this photo?
There's a little bit of a clue in that there's sort of a very, as you mentioned, outer retinal yellowing, especially visible in the left eye superiorly. So that inches me more towards infection, but you still have to go through the process of ruling everything out.
Steve, we obviously you dealt with the medications that we see in cancer medications. There was a great lecture yesterday by Mark on this. I mean, what are your thoughts on like starting these patients who have profound vision loss on prednisone sooner to help them get vision back quickly?
I mean, you're talking about the cancer? Yeah, so I think that if we are thinking about medication toxicity, and I don't think this is a checkpoint inhibitor or TKI type toxicity. I think that in these situations, then you really have to talk to the hematologist and oncologist about whether that's a good idea. In this situation, I'd be very suspicious, again, for an infectious etiology, namely syphilis, because of the well-demarcated plaques that we're seeing.
All right, so you're getting me this guy a third disease. You're a good man. Let's see what he's got. So we start with your regular workup. He does have syphilis in this scenario. So in these scenarios here, you can actually see this is after 3 months of IV penicillin. He gets back 20/40. It took a long time to improve. You know, there's one thing we're really good at in America, and that is getting more syphilis. I mean, if there's one thing that is where I look at the map, it's not just one state, it's the one thing we can agree upon in the United States. I'm really proud of us. So is this something we're seeing in every community? What is
Yes.
happening? I mean, start with Vishali in India. How about you?
Yes, there is almost an epidemic of syphilis in India too.
Yeah.
So you are not alone.
Woohoo! All right, we are together.
And I think it was due to unavailability of penicillin, at least in our country, which resulted in a lot of syphilis and ocular syphilis.
Jen, what are you seeing in Baltimore?
Yeah, welcome to the post-Viagra era of syphilis, right here.
Wow, that was a lot.
Yeah.
All right. Well, it's clear. A reason we bring it up is most of the syphilis is being diagnosed outside of of clinics that specialize in sexually transmitted disease, being made by community doctors like us. We have to be vigilant and look out for this. It's the one thing we Americans can agree on. It binds us all together. So eye syphilis is serious. Don't forget about medications. We will talk about that a little bit more in a little bit. Let's talk about choroidal neovascular membranes, and I specifically want to talk about ocular histoplasmosis. This is a 46-year-old male who presents for an opinion of POHS, 16 injections of bevacizumab monthly for about a year and a half, got an intravitreal steroid injection a few months ago. He grew up in Ohio, but not on a farm. He hasn't been exposed to a chicken coop. He's got great vision, 20/20, but that's his look. So, Tom, when you look at this, does this meet your criteria for what you think of as ocular histoplasmosis? Are there clues here that there's something else that's kind of going on?
I don't know about clues. That there's something else. I guess you're kind of feeding me that.
No, I'm just asking you a question. I'm sorry. Would you rather arm wrestle? We could do that.
This looks like what I would tell a resident is classic POHS. The patient's from an endemic area. They've got Schlegel lines, those linear deposits. They've got multiple punched out small lesions, peripapillary atrophy, and a choroidal neovascular membrane. I'm assuming you haven't mentioned how much cell there is. It doesn't look like there's any haze here.
There's no cell, there's no haze.
So that's another criteria. So you've met all four criteria, and I think we can call this POHS, I have no problem with it. If you're going to feed me to try to think that this is something that looks like POHS but is not POHS, I would think, it would be nice to see multiple fundus photos over time, if available, from the other physician.
You get one fundus photo. That's all you're getting, my friend.
All right.
This is
well,
not the
I might
GA
call the
panel.
referring doctor and say, hey, has there been any recent progression of lesions? Because sometimes you can have chronic inflammation in this setting that's ongoing, and you may have evidence of it by looking for new chorioretinal lesions.
Steve, I'm going to show you a couple other images and try to get an answer out of you quicker than Tom.
Yeah.
Did you see, when you look at this picture here with this OCT and the CNV here, or anything else that worries you? 16 injections, do you expect a quicker response or a more robust response on with POHS? Should I be injecting it this often?
Well, I think that ultimately, like when you think about that many injections over time, the other question is there an underlying process that's actually driving the CNV? With regards to whatever you were feeding Tom with, essentially you want to make sure that you rule out sarcoidosis, syphilis, and TB.
Yeah.
And also in that left photograph, up in the superior field, there's actually an area that looked like old exudate. And so I wonder whether that could be another clue that there could be an ongoing inflammatory process.
Excellent. All right, so here's our fluorescein and our ICG just on one eye. Lucia, does this help you at all? Does this make any difference? I'm seeing you shake your head, not really.
Not really.
So I do a workup on this patient, and we keep treating with them bevacizumab. The workup started for uveitis. Everything is negative. Jen, how aggressive are you at this point in time? If you were suspicious, are you going after anything else at this point in time, or are you happy with your diagnosis? Do you presumptively treat this patient with some steroids? What's your point of view?
Yeah, I'm pretty happy with your infectious workup. So I might try a local injection of a corticosteroid just to see if there's an inflammatory component driving this and may decrease the burden of the need for anti-VEGF, because it's not getting the job done.
Yeah, here's the anti-VEGF looking a little bit better after one injection. And, I try to ask myself how aggressive I should be. Actually, we end up getting a CT chest, and it showed that this patient did have sarcoidosis on this patient. So now knowing, Vishali, that this patient has sarcoidosis and this appearance, would you immune suppress this kind of patient?
Yes, your patient on bronchoscopy has non-necrotizing granulomas. You have given 16 or 17 injections,
Yes.
which indicates there is an ongoing inflammation, which somehow on ICG was not very remarkable. So, but still it bothers me. I would go for local injections, maybe add steroids, but I would treat this patient for his systemic and coexistent ocular inflammation.
Tom, do you think in these kind of cases that immune suppression reduces your CNV burden?
would.
Do you think you get less injections over time?
It would.
Absolutely.
Okay.
Yeah.
All right, so here is the ICG now actually getting worse 6 months later. Steve, does this make you pick a particular drug at this point for your IMT in a sarcoid patient who has multifocal lesions and choroidal neovascular membrane? Anything you particularly start on?
I didn't see that the patient had been on prednisone before, but this is a situation with the bronch that you're already managing this patient with POEM, and so this is really, I think, highlights the need for multidisciplinary care. But I would probably start with oral prednisone and then consider an antimetabolite.
All right, so Lucia, I put him on a medication. He's on adalimumab at this point. He's still getting the injections. My arms are getting tired from the number of injections that I'm doing. Should I push the IMT? We add methotrexate, and he doesn't really tolerate it. I go to weekly. Do I keep going? Do I keep pushing? What would you do?
Yeah, you keep pushing. These patients eventually, in my experience, can get off injections. For the most part, they just need the right immunosuppression.
Yeah, and that's what actually happens in him. Here's over time, the ICG lesions start to go away. He actually gets infliximab. This is him 3 years later. No injections for over 3 years, 2020. And you can see the pigmentation changes now, I think, a lot better. So, Jen, you're shaking your head. Let's school Tom a little bit and show him the clues. Maybe now that we see the pre and post, was there something on that first image, maybe now that we look at that we say, maybe this was something else?
A short answer? No.
Yeah. Okay, that's good. Tom is really happy. The
No.
long answer?
No. I think the clue was you would have expected this to resolve after 12 bevacizumab injections if there wasn't an inflammation driver.
Yeah.
If you had given a dexamethasone and that had improved, I would have gone hunting with that chest CT rather than the other way around.
Gotcha.
But I think you and I are a little similar in our approach. The one other thing I would say is historically, adalimumab is not as effective for sarcoidosis as infliximab.
Yep.
And so that is why perhaps using that as a single agent didn't get the job done.
Yeah, absolutely. Let's move on to our next case, a 36-year-old male, worsening vision, sent by an outside provider for retinal detachment, hasn't seen well of his left eye, was recently diagnosed with sarcoidosis. He's been on topical steroids. Bactrim was added recently, and he had acute vision loss in his right eye. Count fingers LP, so typical patient in my office. Pressure is 10 and 6, 2+ AC cell. There's the look into his right eye. It looks like a detachment. It looks like there's retinitis. I'm not going to make this any real challenge for you, and I'm going to say it's a monocular patient with retinitis and a detachment with a recent sarcoid diagnosis. Let's start with you, Tom. What are you doing in the operating room?
I'm not in the operating room yet. Let's go back to the clinic. I think, we often see patients present like this that have had acute retinal necrosis in one eye and then have it in the other eye. So that story adds up to me as an ARN detachment. But I also wonder, when I look at this, the amount of scarring. I've seen toxoplasmosis-associated retinitis that can look like this. So I'm not 100% certain what the diagnosis is until the PCR comes back. But I think I would try to get the infection here. He's had this RD for a period of time already. I think there's enough time to put him on an antiviral to get and probably Bactrim. I would just try until we get the PCR results back and know what this is. Get the infection under control with antivirals and Bactrim, and then do the surgery in a week. And I would probably do a vitrectomy buccal with silicone oil is usually my go-to in these.
Steve, are you taking this patient sooner than Tom? And Tom's waiting like a couple of weeks.
Yeah,
He's
no,
got to
not
get
a
some
couple
things
weeks.
done.
1 week, 1 week.
He needs all the treatment done. It's a monocular patient. It's fine.
Yeah.
That's okay. Whatever you want,
I'm
Tom.
not sure why
It's a MAC off RD.
I'm not sure why Tom's waiting, but no, I would actually do this workup simultaneously.
Yeah.
It'd be a very long conversation in the clinic, doing the typical testing, and then proceeding to the OR vit buccal oil, but then also getting some serologies.
So
as well.
his PCR is positive for HSV1 in the operating room. Now that we look at him and we know this, Lucia, I know he's got retinitis. So it's all peripheral. Do you inject these patients who you already have on valacyclovir? It's going to go up to 2 grams here in a second, but would you inject through oil in this patient and try to get the peripheral retinitis under control?
If I thought it was still active despite the systemic, yeah.
Yeah,
sure.
so you would do that. Excellent. So he comes back. He's 20/70. I asked him to come back in a week. He follows up 7 months later. So he's back 7 months. His count fingers. He's been off of valacyclovir. I think we would all agree it's probably time to go back into the operating room. I restart the acyclovir. He has no active retinitis. He's 20/30. Vishali, at this point, how long do you treat these patients on? Do you put them on valacyclovir for a long period of time?
If it's a monoocular patient, yes.
Excellent.
And half the dose.
All
not
right,
the
so
full.
he's going to come back in a week. So he comes back 3 years later. So he's back 3 years later. He's got decreased vision in his right eye. It's hard to make an appointment
about
with
right,
me.
yeah.
Local physician sees new changes. When you look at this, Jen, do you think that looks like there's some whitening on the retina here. Do you think this is retinitis? Do you think that this is inflammatory? What do you think is going on in this patient now?
Based on just the history, I'm going to lean toward retinitis,
Yeah.
and that's the thing I would want to take care of first.
Okay, so put him back on valacyclovir, which is what he gets. He actually gets better within a couple of days. And we say, well, why don't you come back in a week? So he comes back 1 month later with a detachment now again in his right eye. We take him back to the operating room, and his PCR is positive again. So this is where he's at 6 months later. I think this guy has bought prophylaxis forever. It's been 4 years since his last follow-up, so it's nice to see this keeps going. Tom, you're going to say something.
Yeah, I'm just saying one of the discussions I have really with patients immediately when we have an HSV ARN diagnosis is that you're going to be on Valtrex forever.
Yeah.
And so I would try to scare the bejesus out of the guy from the beginning to say, you can't disappear for 7 months. You need to be on this drug. And because I've had patients that have stopped it, and 3 weeks later they come back and there's a recurrence. So I really believe in my experience that these patients benefit from being on some amount, not clear what it is, 500 milligrams or a gram daily of drug continuously forever.
All right, last case. I am better because of Dan Martin. 23-year-old male, blurred vision for 2 days. sent to us on Valsite because he's got some changes. Here's this look in his retina. I'm just going to ask what you think as soon as you see that. Vishali, what do you see? What do you think?
This is vasculitis, more like frosted branch. I would investigate for vasculitis causes.
Excellent. Lucia, you got one diagnosis in your mind?
Not particularly, not just based on this.
All right, excellent. So we do a workup on this patient. Other eyes fine. Has a new cat and a new partner. So you got to test for all the things that a new cat and a new partner can bring you. And review systems is negative. The Bartonella is positive. Do you think it's Bartonella?
Doesn't look like.
Doesn't look like it, I agree. So here's he getting better 10 days later. Everything is improving. So the follow-up 2 years later, that's how it works in my clinic. He comes back in the other eye and now has a new lesion in his left eye. So now that you see this, what's your diagnosis now?
So if you see the right eye, the vessels are occluded, and left eye has this patch, retinitis patch. Looking at both the eyes, I would do the fluorescein to look like fern-like leakage, and Behçet's would be on top of the list.
So that's what I thought as well. So I now ask him about his oral ulcers in incredible detail. He only gets sores when he eats too much pizza. Genital ulcers, I asked him before, but I gave him a very detailed description. He had a sore on his penis, is not sure where he's from. He thought his partner was biting him, but it is an ulcer. And they both had a full body rash 4 months ago, and both syphilis positive and treated with antibiotics. RPR is negative. This looks like Behçet's to me. We started, I know you're going to argue with me, Tom, but we have no time, because I wanted to say one last thing. I've become better at asking about ulcers. I'd like to thank Dan Martin, wherever you are, who taught me a lot about life. But one of my favorites is there's an art to asking about genital ulcers. You should learn from me. I'm one of the best in the world at asking about genital ulcers. We should all learn from Dan Martin. Thank you very much, everybody. Have a great, and Dr. Bellotti is on way back. Nice job.
Thank you all. What a great morning. Now we have a break for lunch, and we will restart at 2 p.m. So get some food and enjoy.